We will be transitioning into our next session, and I'd like to introduce our moderators today, George Jescu and Taras Malay, and they will lead our very important discussion for the next hour and a half, talking about the scalability of mental health care in Ukraine. We do have some remote participants as well, and they will lead us through the session talking about how we go through the discussion, and I'll hand it over to George to start us in today's interactive collaborative discussion.
Добрый день, good morning. Let me ask for a show of hands, who is more comfortable hearing in English what we have? So, okay. And who's more comfortable hearing, кому вигідніше слухати українською мовою?
Who finds it comfortable to listen in Ukrainian?
Does a translation headphone have one? Because I think there are a few more Ukrainian speakers than there are English. So I'm hoping everyone's got a live translation, tak? So we'll try that, but if it gets slow, let me know and we'll switch back. То добрий день, вітаю вас, колеги. Називаюся Юрій Яськів.
I'm Yuri Yaskiv. That's my colleague Taras Makhlai. We're the doctors from Ohio, Cleveland State, and there will be a different format. It's not teaching. We're not trying to overburden you with what we don't know, so it should be a common discussion to raise common topics and hear your feedback and proceed with recommendations. So by the end of the day, we should have several proposals on further action, which will be taken seriously on how you work. Because I'm working from USA, I wasn't in the army, I don't know what's going on in the trenches, so I won't be able to tell you something that I don't know and you know, so we'll have you down to a discussion to come to a certain point. There was a proverb in Soviet times, like, it's a piece of cake to build a house, we'll paint it up and we'll live in it. We don't want to do like that, right? Like I was taught by different people. So we want to have additional and practical proposals judging by your activity. So our main topics for today. So topic 1. How to have the experience and how to scale it up that is needed by the government. Topic 2. What are the new methods for psychedelic therapy that can ease the works of the people and lead to decent results, and what are the other subjects or methods for rehabilitation? So, question 1, how to scale up the knowledge up to the needs, because first condition is what are our requirements, and this is an open discussion. So I'm asking people present here, how, judging by your experience, how do you cope with your requirements and consolidating your resources? So what are our grounds? And we don't have to declare something undercover of everything that we can hear. So please, the doctors who are involved in healthcare, please report on how is it going on and what kind of lacks do they feel. Do they have everything enough? If everything is enough, we may go home now. Good morning, I am Taras Makhlai, a therapist from Cleveland. George has told everything. We will start in a moment, but I wanted to understand who are here, how many psychiatrists do we have here? and psychologists. And who are not psychiatrists or psychologists. I know those two are from Ohio, Annabelle and Craig Bryan. Uh, they've studied in Ohio University and they are psychologists, so we'll ask them about their opinions on how you think. So let's start. Good day. I'm a practical psychologist and I started my activity just a year ago in this area. How do I cope with my resources? I have a computer, I have a cartridge and paper. I buy it myself to fill up the cartridge. I've made a lot of small books needed for soldiers on different topics according to their requests, and I'm showing them films. So I made lots of printouts, like a film Secret in 2006. Americans have raised a good topic there. And I have booklets on resources, how to ensure that soldiers really can rely on it. I have also small books made by myself, or even the notebooks for them to make notice, like Code Injure notebooks. I bought a book and I provided a number of blank pages, and I'm giving these books to the soldiers. And I'm trying to give them a message asking like what they need, what about their sleepless nights or requirements, and I provide information in different methods to recreate. And some have read and they say that I will bring this book to my co-fellows, and how the best rule, I'm giving books on Sun Tzu, The Art of War, Brian Tracy, some business books. So I'm giving them hints that they should leave this circle of the same old things and they can manage with their problems, and they should think about the future because they delay their life and they might not know where to go and what to do. My question to you is, one day in your stationery you have 6 places and you have 12 patients coming in. Who will decide who who will be the first one? How do you estimate who will be the first? How do you triage? When I came to work, to my workplace, and I tried this out, I I decided who was the first to come. So I made a cold call and asking, "Can you meet me?" And then person visits me, and when we talk, I discover their needs. If they have some extra needs, they come back to me. If they don't need anything, they resolve their issues with the health further on, and they keep on discussing their health issues with some other doctors. So I'm trying to talk to everybody in my list. Yes, well, but if there is limited work hours and different systems are sending you some rude patients, who will decide? I decide, because I have my working schedule and I have a list of incoming patients. So during the cold call, I make contact, and if a person wants to talk, they come. So you judge by a phone call. Okay. Another question: how do others do that? Because in my experience, there is a certain couple of hours, but the inflow of patients is quite high, and there is a system on deciding who do we accept or not.
I need to go to Supreme Scientific Meeting of our university. Перепрошую, бо я вриваюся. I'm chief of, sorry. I'm chief of head of Department of Psychiatry, Psychotherapy and Medical Psychology in this university. Можливо, я перейду на українську, так буде швидше.
Your question is very practical because I have a lot of experience and I'm happy that the beginning colleague is starting his career and I'm in this career for 30 years. As for the general level, then our main peculiarity and main requirement to your question is to coordinate all the system of help provision because I'm happy that the colleague from the Angel Fund is offering such kind of assistance and the colleague is sharing her experience and in reality we have a state system of provision of health and that's working. It's working because the main issue with clients or patients or people who have some issues with mental health, they still go through a widespread state system. We have a serious voluntary system of public organizations and volunteers, and they really provide great help, especially at the front line, to all the people there, uh, the people who need some assistance, and they do it in a short time. Like they need to transport people out because next week we are invading with OK's West, and I'll deal with conflictology between the conflicts between the military psychologists and the military, so it's a different part. Plus, there is a private practice which is widespread in Ukraine and it also provides some assistance, but private practice is does not has a small limited number of people they can help. Then training that was mentioned during the first speaker, and there is a great requirement for specialists in mental health because we have a lack in psychiatrists, like children's psychiatrists, etc. So there is a wide education of medical psychologists and clinical psychologists, but still there is a great need for psychologists, and we need to train people, the doctors on the general level, those who face different mental issues. What I mean and what I insist of that the system does work, but in some areas it can be still stiff or work in the wrong way and it still needs more coordination work. If this can be done, I'm not sure because the state is in very scrutinized and I believe there are some colleagues and they will tell this, but main thing that we need is to do what we can in our place within our limits because there are lots of tasks. They're quite different. But what I want to say is this. And on your question on new technologies, uh, I would say that I met some colleagues here. So main task, if there is a PTSD, what has to be done? We need to transport a person outside the traumatic area. And if this is war, then there is a problem with rotation of military, and we need to ensure, or if there was a missile attack or a bombardment, how can you transport a person out to the safe place? So we have to adapt ourselves to what we have and work in the conditions that we have. And this is our reality. Do we need the new technologies? Yes, we do. But we need to understand the capacities, the widespread, the protocols, the rights and obligations of those who will deal with this. So I'm sorry for a very general information, but we need to take a look from different perspectives and from general area and in practical area also. So I'm here for 30 years as suicidal psychologist, and our big problem is the youth, teenagers, different types of self-destructing behavior that need to be attended to. And I believe there is a big need to work with audience of teenagers and youth. I'm sorry, but I need to run, but I'll come back in time. Thank you. Ksenia wanted to say something. Okay, I'll tell you something. I have 2 points to mention on the specialists and the PTSD. As for the specialists and their training, in 10 years of war, there was a big pool of specialists which was created. I'm proud of that. These are people with experience, people who implemented international experience and protocols to Ukrainian context of war. And if we give deep education, then yes, we need more specialists because the volumes are growing. And when the war is finished, the physical trauma will go to zero. There will be no new amputations or severe wounds, but the mental health issues will grow, especially with the soldiers. And here I wouldn't be using the wide international resource as for trainers because we have a lot of trainers in Ukraine. I would support Ukrainian trainers to spread the information further on. And what is important here is what we're asking, our team is asking from international partners, and I'm not sorry for asking for that. Because if we're not healthy ourselves, we won't be able to provide assistance to others. That's the main rule. So today in our site, we have 230 to 140 patients who are beautiful guys and girls without any wounds but with invisible traumas. And when you walk through the corridors, you can feel that in the air, that you can just hang an axe in the air. And right now I have quite a big team, less of psychiatrists, but psychotherapeutists like 20%, social workers, clinical case managers, which are 8 girls. So that's the team that daily deals with severe conditions. And we have an experience of getting help from international specialists to organize retreat for my team, and the people can cope, can become stronger. All the people who's been working with us, they work for a number of years and they don't want to change their place. We provide a lot of supervisions, and international partners can provide free supervisions for our colleagues because they're quite expensive, but the uh, psychological specialists, they do need that because it's about the care of their condition. And even now, the German Doctors Fund is bringing 3 groups of our team's doctors, case managers, and psychotherapists. Like, we can't leave all of them in place. So 3 groups are going to a spa area to relax. Everybody's happy and everybody comes inspired and ready to fight with the situations and support the soldiers that are defending us. The second thing, I don't remember if I mentioned it yesterday, but I have an experience of working with the military and veterans and the work that we perform on our site. I start to believe that trauma is a different disorder of psychology which can be treated and overcome, which can go to post traumatic growth. But to achieve that, you need to deal with everything you can, like a psychotherapist, psychiatrist, physical therapist, ergotherapist, social work, family support, directing a person from highly specialized inpatient to a community with some contacts outside a person can use in the community. Like, you're not releasing a person, but you hand over a person from highly specialized to a community. And such multimodal approach, this is the only way to overcome the war trauma, because a psychotherapist will not cope only by himself if there is no comorbidity. I mentioned about the Ukrainian challenge, which is a light skull brain trauma. And if you're working as a psychotherapist and you're lucky in it, that's good. But if you have some uh, flashbacks from other symptoms, then that may complicate your therapy, and you need to have a physical therapy, and it will be hard to overcome if it's in the group of specialists. So such post-trauma model have to be spread all over Ukraine, and this will provide a possibility to bring back the quality of life to those people. I'm a psychiatrist of the first line of a local psychiatric hospital. I don't have a big experience because I just left internship 2 years ago, but I do agree with the previous speakers that we need a multimodal approach to rehabilitation and therapy for military and civil people. And I want to say that for me, the biggest therapeutic work was done when outside the hospital in social life, because that kind of work does not stop only by prescribing drugs or discharging a patient. It has to continue even after the person leaves the hospital, and in such situations as war, anything that can used for therapy will be used for this goal. And I was really good to know the behavior of soldiers in different social situations through a playback theater. That's a kind of a theater. It's unofficial psychological therapy. It's more on entertainment, but that teaches people emotional intellect and how to work with emotions. And also the board games, role games like Dungeons and Dragons, and because such situations creates typical social situations and help release the emotions that cannot be released in other way. And I believe that if something is working and something helps to diminish the level of stress the person had due to war traumas, this has to be included and prescribed to the patients at times. Greetings, I'm Anatoly Tikhonchuk, a military officer. I'm 67, and I wanted to share a project where the medical officers are performing their duties independently if we're 60 plus. We've arranged a program to arrange support to soldiers on the battle line. It's a unique project, and I know there are some colleagues who are implementing this project. These are trained specialists with a basic education as psychologists, like I'm a PhD in psychology, and I keep training from my colleagues, both from US, Great Britain, and Israel. So the experience that you are eager to share. So we created mobile teams of psychologists, and with the help of the NATO office, we're implementing uh, we're engaging military units with tactical psychology. Like we have tactical medicine, and the tactical psychology is aimed at provision of assistance to a soldier right in the trenches in the front line. This is quite risky, but we've selected a group of people who are psychologists who can jump into the front lines and work in extreme conditions to providing help to our soldiers, who can tell them about their conditions, who are under stress, and they teach the soldiers how to cope with the stress. Of course, the IFU have some military psychologists and the Department of Stress Control, but alas, and it's an honor for me, like uh, that's the way they were trained. They do a lot of paperwork somewhere in HQs in lines 3 and 4, They uh, do the investigations on the second line. They test the guys there, and they are done with their work. But independently, I am a captain of a first rank. I was a captain of a ship previously, but and my colleagues worked as soldiers, and we keep working as soldiers, and we address each other as a friend, which is more important. So we're not communicating on a vertical level, we're communicating horizontally. So when we are in the first line, besides the psychological issues, we are also talking about duties and legal issues of this, that the soldiers may have, because it's quite complicated. Because the soldier who is in the trenches, uh, he is considered as a wasting material. So we're talking about the saving life and saving psychological conditions of the soldier. So when we're asking a soldier, what is your main function? He says, like, perform the task and die, which doesn't sound well. So we say, you need to save your life, you need to save your friend's life, and your task and his task changes. Then he is ready to perform any military tasks if we're talking about the rules and how to save his life during the battle. Because on the same side, there are Russians whose task is to kill a Ukrainian, and our soldier needs to kill the enemy. That's why he's have the necessary skills. So becoming a soldier into the warrior is a separate topic, but when he's transformed into a warrior with a weapon in his hand, he needs to fight his fear first of all, and he needs to perform his task and kill the enemy. Of course, the stresses that are related to this, and the colleagues mentioned that. But what else is happening? He has the experience of PSD, and our colleague, like Ms. Ksenia, talked about her side, and thank you for doing what you're doing, because our soldiers are being recommended to attend you, and they have their free space there, but they also have the license to kill, and you can imagine that this license for a person who comes back to a civil life still remains as a license. And when I was there for a week or two at the front line, and I need to come to a shop or some social service, and I want to have a different attitude because I was there, I've victimized my part of life, and there is an official who does not even notice me. He doesn't want to talk to me, he's too busy, he has his protocols. So that triggers me as a psychologist, but I'm teaching the boys that they need to resolve the issue quickly and with force, and that saves them from being killed. So right now, back in civil life, I need to perform the task quickly and with force, and no triggers can stop me. I start shouting, touching the official, though I'm a psychologist, but I can't cope with myself, and I can imagine how the soldiers are dealing with the same issue. That's why they have families issues and social issues, and the social environment has to be ready. You don't say this is a PSD victim, but we need to understand that this guy has survived because he was performing quickly and in force. When he comes back, he needs some time to recuperate. So for psychologists, it was 3 minutes when I talked to guards because I was going to a lawyer, and the situation in their office changed, and they needed to arrange the guards. And they previously everybody knew I'm a veteran, and they opened the doors with honor. But then the rules changed, and there were 3 guards, and I was shocked. Like 3 boys did not let me to the lawyer, saying we're not letting you in. I called to the lawyer. I was waiting for 30 minutes. Like they didn't provide me water or chair. So when the lawyer finally replied and said, "I'm sorry, I have a client," I was totally lost. I was swearing everybody. That's my personal experience, and that's what we need to work with. And the program of tactical psychology is the preventive measures, where we how to stabilize this mental health of the soldier, and we provide them a lot of trainings how to cope with different system, and even breathing system is very good for them, and they manage to control their processes. I'll stop talking now. Maybe during other panels we'll discuss these issues, and thank you for your attention. Thank you for having a good experience. Thank you for creating the mobile teams and mobile cars who are asking our boys. But my question is, the front is stretched for kilometers and you have limited number of people. And how often does a soldier manages to talk to someone? So my question is, are there means that a person can rely to scale it up? Because you are the resources, you're the main resource, and there is a small number of you. So how to take up your quantity and use your skills to provide survival skills to the soldier. Uh,
It sounds to me, and forgive me if it's coming off, your issue is not skill. There's all of you in this room that care deeply about this issue. You want to save the people. The issue is, how do you scale? How do you get access to the soldiers on the front? You're creating an amazing team, tactical therapy, to go out. I myself was a soldier. I fought many wars for my nation. I created my company because of that scalability issue. Utilizing technology like virtual reality to give access to therapists here to the front line for rapid treatment. My colleagues from Ohio talk about it. The faster we can get treatment to the soldier, the quicker we can recover them, the more we can avoid long-term issues. From a scalable solution, we don't have time today to talk about the modality of therapy, but we need to talk about and decide the rapid scalability of therapy. How do we get access to those that need it in remote areas where we don't have 20,000 therapists to treat everybody? How do we get that access and grow it? That is what we need to talk about today. That's what I'm here for with my company and what we want to help with. How do we get access to the people that need it in the front line, and how do we scale that to be the efficacy rating higher, treating not just the psychological issue, but the neurological damage that comes with it.
Okay, thank you.
Hello.
Добрий день.
My name is
Oh, that's okay.
my name is Craig Bryan. I'm a psychologist from the United States. I'm also a veteran of the U.S. military. One of the lessons that we learned in the United States over the past few decades was that we can position certain therapies very far forward to reach service members and soldiers experiencing combat stress. My own experience, I was deployed in Iraq, was shoulder to shoulder with our fighting forces, and what we started doing was implementing PTSD-specific therapies very far forward in the combat zone, and started to deliver them in a scalable way that now is referred to as masked or compressed trauma therapy. We know, based on several decades of research, that there are a handful of counseling strategies, therapies that are incredibly effective for reducing PTSD, promoting recovery, return to duty, keeping soldiers in the fight. We, in essence, trained our behavioral health providers how to do those therapies, and then positioned the clinicians in the combat zone so that they could immediately start working with soldiers as soon as they were exposed to potentially traumatic events. The good news about these therapies is that they also work for civilians. And we're now providing these therapies to family members, to children, to adults, anyone experiencing any form of trauma. And we can now successfully treat PTSD in as short as 2 weeks, sometimes even faster. And so perhaps one piece of the puzzle here is making sure that your behavioral health providers know how to do those therapies. We also have seen in other nations, such as in Africa during civil wars, there has been successful training of non-professionals, of members of the community, family members, community leaders, how to do these therapies, and been able to successfully help the population at large during the midst of war. And so we could potentially look at how to provide access to those therapies, not only for your military, but also for your civilian population as well, and how to start implementing them not only face-to-face, but also potentially virtually, remotely, whether that's online or through some other at-a-distance method. And be happy to provide additional information or answer questions about how that might work. So thank you.
Окей. Так, я, мабуть, стану тут, щоб все ж таки всіх бачити.
I will stand here to see everyone. Oksana, I'm the representative of the American Foundation Heal Ukraine Trauma in Ukraine. We specialize on helping Ukrainian veterans. We have a separate section on children, but mostly on the veterans. And on the up-to-date techniques to help mental health. Psychedelic assisted therapy. Our founders had PTSD in her life that disturbed her life for a long time during her career. But it's hard to live with it, the people who know what it is. And only in 2016 she was capable. And she had access to any methods, any therapies, medicals, medications from the US, rich person, and nothing could help her. She was resistant to any standard methods. Psychedelic assisted therapy without symptoms. She started since 2016. She worked in 90s in Ukraine. She knows Ukraine very well. When it helped her and she healed with it, she understood that it is necessary, and she started to develop in Ukraine even before the full-scale invasion, because we had war started 2014. And this problem, and the Lisa Vapalana is working with this for a long time. There are people who sought it beforehand. So we started working since 2022. In 23, we had the first conference in Lisa Vapalana Hospital regarding the psychedelic therapy and new methods. But now I want to talk about scaling. We also thought about it from the very beginning. If we speak about psychedelic assisted therapy, what's good with it? The number of hours that the therapist needs to give the patients, it decreases. So it's not a magic pill that helps itself. No, it's therapy, which comes much quicker, but you work with a therapist. You need to know how to work it, and of course it's hours of work, and it's a professional work. But if we speak about psychedelics session, it's a specific number of hours when two therapists are working with the patients. So it's hard for scaling because it's resource demanding method. So we started with group psychedelic assisted therapy, and our foundation deals with training, education of psychologists, psychology specialists who can assist and give such help in Ukraine. In Ukraine, psychedelic therapy, we only have ketamine assisted therapy. Legally in Ukraine, we have hospitals with ketamine therapy, and as far as we know, all the hospitals are working independently on that. This year, this Sunday, we finished the first course for 8 highest possible level psychological therapies. Some of them work in Lisava Polana. This is world-class specialists. They had this course, and now they have the ability, with our help, with our communication, because we're giving they're giving feedback to us. Now we can scale our program and help much more people. So this is one of the attitude, how we can work with that for individuals and how we can scale it for groups. Also wanted to tell about what we've told just now regarding the therapists, professionals that are working with people. We now were training 8 people that are working with military personnel from Kiev, Sumy, other regions. They have crazy schedules. They are overwhelmed with work. So these people have the highest possible resilience because they work many, many years. They know how to care about themselves, but they need support as well. They need help. You need to think about it. And if you are speaking about the scaling and for the scales that we will have after the end of the war, the victory that we are all waiting for, it's an exponential problem. And these doctors would need our support as well. So let's talk not only about the patients, but the pressure on the doctors. So yes, ketamine-assisted therapy. We've trained first aid people. Starting new year, we're starting the next course for 8 more groups, and we're expecting for each of our therapists to spread it exponentially and to do more groups of 8 people, 8 to 10 people. Thank you.
Dziękuję.
Hello. Vladislav Metrenitsky, PhD, first of the Ketamine Center XPO in Ukraine, founder. For the past 6 years, working in this sphere, we have very good experience, mostly in resistant to medication stages and for PTSD. And what's important in this sphere, that the technology that we have, that we developed, it provides the ability in the resistant cases for PTSD to help the veterans and militaries. We are speaking about the ketamine therapy. We will have a separate session on ketamine, so I would call you on that session. So regarding scaling, we can help the patients during the months, 4 6 weeks. We're healing them if we compare with half a year standard therapy for the same results. But we need to understand that this therapy needs to be developed. It should be not only exist in 4 private hospitals as of right now, but it should be on a state national level in all hospitals. So state protocols do not have this methodology right now. So the state hospitals do not want to work with this. So we are planning to start the clinical trials on ketamine therapy for PTSD to give the base for the Ministry of Health to assess it and to recommend this therapy and it to be included in the healing protocols. But there are problems with the financing as the military is dealing with us and asking for help with this. Of course, we have the capabilities of the free of charge therapy, but we are not capable to cover this for ourselves. And there is a paradox right now. There is an effective methodology that works well, but the government couldn't fund it because it's not included in the government protocols. So we have to ask charity foundations and sponsors that have the ability to support and to heal these patients. So I think that the more we and Lisa Vapalan and our colleagues from Heal Trauma Ukraine if we would show more results of our work and represent it in the Ministry of Healthcare, the sooner they would open this therapy for the general public.
Minute for translation as needed. My name is Megan Williams. I'm the mental health advisor with USAID Ukraine and a psychotherapist myself specializing in trauma. And I think one thing that can bridge our conversation on scalability is who needs what intensity of treatment, and then what provider level is needed. I think, as our colleague said, some traumas have been resistant to some of the lower intensity treatments. Yes, then there's the need for these highly specialized treatments. Do we need more of those? Yes. But there are also a lot of people who, I think, as our colleague here said, with lower intensity interventions that do well. People are resilient, they build on their strengths. And also, and that's where I was happy to see on the slide, MHGAP, WHO's Problem Management Plus have evidence that they are effective of treating people in conflict settings and helping not all, but a lot. And then that comes to our referral pathways. Of those who do, the protocols with the lay counselors, how do we refer them up to the specialists? And for those who are being discharged, not released, as Zenia said, but handed down the ladder to other care. That is really, I think, the key to scalability at either end, is an effective referral system of specialists to non-specialists and back again as needed. So.
Thank you very much. Дуже вам дякую.
Thank you very much. It's very interesting for me, even if I'm working as a civilian and I'm not in a conflict zone and we have more resources. But the questions that we face, we face, even in the US, there is a deficit, the lack of the psychologists, and we couldn't cope with our own needs. That means that we have the same problem, that we need to involve people that have less training, but they are competent and can solve problems and help with solving these problems. So these people, like nurses, they can decide whether they see the potential in this work, and they can help with that. They need to be trained, of course. So we are giving, of course, electronics, diagnostic materials. It doesn't work for the person in trenches, but for the people that are at home, they can use it. So the question is, if you have 1 billion UA hryvnias, what is the proportion of the psychologists, therapists, nurses that we need to help? I don't have this data. I don't know. But again, only doing work, you can understand what needs to be done. So we need to find out what the proportion of the people we could use and help, provide with help to scale this program.
The data we do have on conflict-affected populations in general, WHO has found and published in Lancet studies that the point prevalence rate of mild to severe disorders in a conflict-affected population, so fighters and non-fighters, 22.5%, not about 9.4% moderate to severe disorders. I think Ukraine's situation is unique given the large proportion of the military and veterans. And I think even the numbers we have from US veterans exposed to combat aren't going to be reflective. So I think that's a question I would put out that would be helpful. What are the proportions of veterans, mild, moderate, severe? Treatment resistant, not treatment resistant. That will help us plan those 1 billion hryvnias.
Чи ці цифри є державною, вони є
Others figures are provided by the government. Do we have access to this data? This is the question. So the second question was what we have budgets, how we can cope with that, what means we have. And this other question, do we use the system that we have nurses that are competitive for the first level assessment, please? In the US, in general, recently I've started reading the great book, Work with Heart Traumas and Mental Health Problems. It has described the middle level of the personnel of the hospital, how nurses are helping with patients, conducting psychological work, but within the full-scale invasion that we have, and the situation on the front line and the post-Soviet development of the medical system, the middle and the junior medical personnel, they're not prepared in the hospitals and in colleges, like specialized colleges. It's just a standard uh, training, standard education, like manipulations and others. But how to work in the frontline units or in the vicinity of the frontline users, you are working not with the doctors, but with a surgeon, with a battle medic, because in healthcare facilities under Minister of Defense nurses, there are usually surgeons, and usually the soldiers are speaking with sanitars, with nurses, and sometimes sanitars, nurses, they do not have enough capabilities and knowledge what they need to tell to the military. But of course, on my own experience, because I have the experience of the middle level medical personnel, usually the part of the psychological, if you name it, work is done on your own level of understanding and just on a human understanding of the soldier. Of course, we cannot understand these factors that lead to mental health problem, but we can give the facility of the safe environment for the patient. But regarding your question, does the government have the proportion on psychologists, middle, junior level of medical personnel? I think it doesn't have it because, as a minimum, the goals that they given to the middle and junior level of the personnel, they are not capable to providing and solving this issue. Thank you.
Дякую. Отже, я не знаю, як там є в ніколи не сидів, але чи
I was never in trenches. I do not know how it is, but I would like, by the day that they come, their needs would be followed. So yeah, please tell me how it is on the front line. Does this surgeon has time and to work with these protocols? So surgeons have some of the preparation and training to provide these services. So at place they try to work with that, and the the Surgeon Institute, this could help Ukraine to fight the enemy. Do the surgeons have the proper training? Do they need help with mental support? Yes, there is the training for the battle medics. It's a regular soldier that can pass a 3 months course, but it's not enough. And there is the risk zone for these medics, and this is how they get into the burnout process. And you need to work, special work done with them. For them to understand their own health is more important, because it's not like I will be here a couple more time, but it's a problem, long-term problem. You need to speak with them and to persuade them they need to preserve their own house, and only in this case they can help more guys. Okay, let's summarize for the next 20 minutes what we've spoken about. What recommendations do we have? Dear colleagues, I would like to advise and ask a question regarding the stages of the attitudes to the mental health. Of course, we understand on the front line, people more facing evacuation, sorting, triage, and treatment of the patients that the surgeon yesterday did, that was using tourniquets, physical traumas, and there is no time for the mental health for that. So my question is, to your opinion, where should be this island of the first mental health support and healing of the mental health? First question, maybe you have some methodology or thoughts on that. And also there is also the forming the wide sphere for the perspective work with mental health. We have trainings under World Health Organization for the match gap for the family doctors, the people that are demobilized, that are veterans, so they can have support here. In example, there is a question on our example of one of the biggest facilities, a psychological hospital. We got all the needs supported with a good staff members. We have social members, psychologists. They were providing help with mental health, but because of the reform of the mental health in Ukraine, we got reduction in the personnel number. So of course it was mobilization of the resources for the war. And what is in the perspective? I want to hear your opinion, how it would look like. Are we fixing this problem? So we see the gaps, that we need more support, personalized support to every soldier, and how we would deal with that. To your opinion, any thoughts on that? Thank you.
Hello, everybody. Sorry to introduce myself first. I'm Brendan Barman, PhD. I think Ukraine sits at the best possible situation for innovation in the world. You can learn from our mistakes in America and our wars and how we decided to filter and triage. And you can implement programs like my colleagues right to the front line, peer-to-peer, all the way back to where we have patient resistance specialists in the filtration of where do these patients go. Ukraine sits in an opportunity with the right innovation and the right techniques to maximize potential of treatment and set its own standard for the global stage of how we move forward in future conflicts in other countries around the world on how we treat these patients. Right now, we've talked a lot about soldiers today, but you have an adolescent population in Ukraine. They're going to be your war for mental health in the next 5 years. This doesn't end when the war ends. This only gets harder. So if we can implement the right filtration and standard treatment of care from peer-to-peer to specialists across the board, I think Ukraine sets itself up to be the global leader in how we move forward with these treatments. And I think that should be the focus of right now. Instead of learning to run right now, how do we treat today? You have to set up your foundation of how are we going to do this correctly today, so that way you can move forward with the crawl and then the run, and then you won't fall. That's my advice.
Thank you, understood.
Це буде останнє, тоді будемо писати підсумки. Прошу.
This would be the last, so let's summarize it regarding this question. To get to the first level of the help. Sir Officer told very good how it doesn't work. The Staff Institute of Psychologists. You know that in Armed Forces of Ukraine, on each in each battalion they have their staff psychologist. It's an officer with any education, like let's see psychology, which receives salary, he works, but it doesn't work. Why it doesn't work? Because, in example, we were dealing with great, I don't want to say good words towards Lisa Vapalana, because I am, as a military medic, I was sending my guys there for treatment. With Natalia, we were negotiating each time because there are no places for soldiers there. It's not a big hospital. We need their experience, their capabilities to multiply them. Yeah, I want to defend armed forces of Ukraine because we have international specialists here. I want to say that on the third year of war, armed forces of Ukraine are changing. We don't have uh, that lack of the moral supplement, but we have already the psychology support groups and the battalions that they have the control groups for the mental health. They have the capability to work with mental health problems because sometimes they have psychologists. Even one of my psychologists work there in a battle group for support. He has also 2 3 psychologists with him, big brigade, and they move between their own brigade to control people, to proactively help people, and this leads to very good results. Of course, this system doesn't work in the full scale, but we have already good changes in understanding this, and in military psychology it's changing. They are in the very beginning, and it's already good to hear. Thank you very much. I wanted to add that we did a analysis before the war regarding the mental adaptation of the military. So we understood that on the front line, so we provided recommendations to our military.
Після бою
So straight after the fight, they raised questions on how the soldier behaved during the battle. So that was a quite complicated practice. And we provided a number of recommendations on how to train and create the necessary skills. Both recommendations from military hospitals, so all this was implemented, and a state award was rewarded to us. So back to your question, I understand that these principles are being implemented, but not as quickly as we want, because the combat situation is quite complicated and it requires a lot of resources. Maybe people sometimes fail to provide the necessary help due to that, and that's an interesting question to me. I want to say how we use this in practice. We must not forget that a soldier is someone's father or son, and he has a family. According to Ukrainian tradition, family is very important, so we focus on families also. So when we work with a soldier, we definitely work with their wives, parents, and we tell them there is a change on a psychological level, and the soldiers come back as a different person. It won't be the same guy before the war. And the family starts to understand that, and lots of wives are being trained or become therapeutists or psychologists, which is very good for Ukraine. And besides, we also try to unite them into a community which communicates within itself and provides good support. So when the soldier calls or just puts a like on social media, the wife needs to say, "I support you." You're not asking like, "How are you?" You're saying, "I support you," and the soldier feels quite well. So that's another plus for our situation. Thank you for your question. Uh, Thank you, but you're talking on general topics right now, so let's make common conclusions regarding our discussion. I can hear, and which is not a wonder, that there are not sufficient number of workers and resources, and we need to multiply that. Back in America, we say that we need to multiply the force, but the question is how to do that. So question one, after the discussion, is there a good ratio between different disciplines, like because psychologists and psychiatrists are well trained, but they are less in number, but are we adequately using them and their services? Is the proportion relative to the budget, and do you have the force to implement that? Are there any people that can be engaged as psychologists of a certain level? So this is question one. Question two that you have raised is there are technological methods that can be used at the front line and insist on a psychiatrist being in the battlefield electronically or in advance. So that's another interesting question. I'm not familiar with that. I cannot comment on it, but I would like to study this if this can adapt it to the needs in Ukraine. So that's my second topic that I can hear from the audience. And the third thing, there are some of you who are working on the third line or working in the first line. So my question is, do you have a good coordination between yourselves? Can you communicate well so everybody knows what's going on in his line and what's going through? Because I wasn't there in the front line at all, but is there a forum where you can exchange information on who is doing what? Is there such a service? Generally, we're meeting at these areas like forums during conferences, seminars, and thus we arrange the XCAS. And is there a regular forum which can be the general source and you can know what your fellow colleagues are doing? Well, there are some forums, but there is an exchange of thoughts on different levels. Yes, there's a community of psychiatrists and psychologists which is very active, and we're looking for additional contacts, and we're creating our own communities, so we're quite active in this area. So my question then is, like, do you contact yourselves or MHO or WHO or the state? Is there any system? And do you know who to address to? Does it work integrally because the resources are limited and the budget lines can be different? Our situation is that the specialists can easily communicate between themselves, like psychologists of a military. We know all of them and they know us. So if there is a conference or a forum or any interaction, we resolve the questions together. But we're on line 3, but line 1 is for military psychologists who are communicating back to us. So there is a professional community, a professional link. And we've also heard there are some ketamine therapy. And I can say that back in US where we work, ketamine therapy is not prescribed for PTSD, only for depression. So we have some researches that are still ongoing, and the states will not allow to work the system to work separately. It may take years and you can't speed it up. But in our system, we have a system which drugs are permitted clinically. Right now, ketamines are not permitted in our states, but there is a need for further research. What other conclusions can we make to record them down in our minutes? We have another 5 minutes, maybe some general claims, questions, concerns, anything, hallucinations. Yes, please. Тут про галлюцинации.
But as far as collaboration, hopefully you all have received an invitation to the WhatsApp community. Certainly that is a very tangible thing for all of us here today to continue to collaborate, to continue to keep the channels open, and to continue problem solving together, to raise the issues that we're talking about and have a forum beyond today. And if you did not already see that WhatsApp invitation, look through your email. We will also continue to publicize it in the email and on the online platform through Ring Central, the invitation to join that WhatsApp community. We have many people already have started to join it, and we'll use that certainly as one forum for us to problem solve together. But what I would love to hear in the last few minutes is, what specific committees might we form, any other groups that we might be able to influence, right? I think we've got representatives from different organizations that can go back to those organizations. And also, I think we would also like a volunteer to be able to summarize what we've been discussing today at the end of the session during our closing later this afternoon.
Хто ще має зауваження?
Any other comments or questions before the break? Like everybody's exhausted, so we need a break. And we're also looking for a volunteer, maybe someone young. Nobody will volunteers to make the conclusions by the end of the day. Okay, we have one. We've appointed a person to be a volunteer. Thank you. On my side, I don't have enough skills. I'm an intern. I didn't work with soldiers, but in my circle, there are soldiers, and I can see a huge problem in the situation when, like, we have stigmatization of psychological assistance, and people run away to different abuses like drugs or alcohol, and that's a big issue. And those people don't see the risks of jumping to abuses when they need some urgent support to cope with the stress. And maybe they are getting kind of psychological support, like remove all the anxiety. And I understand the situation, but I would like to find out how can we foresee such situations for the future, because the war may go on for a number of years and such a number of such situations can grow. So how can we warn these people from doing this? Maybe we'll come down to this after the break, because it's a chronic issue, because as long the war continued, the abuses continued also with different stuffs.
Маємо кафеїн.
В принципі, якщо вам потрібно поправити запаси кофеїну, будь ласка, спускаємося вниз. So we can go down and have a break for 15 minutes.